So for this short video, the patient's on ACVC, PEEP of 8, 5 cc's per kilogram of ideal body weight, FiO2 requirement of 100, and the SpO2 at that time was 90%. We installed the Palmavista 500, which is an electrical impedance tomography. If you look on the right of the screen, you'll see 32, 53, 5, and 9. Those are the percentage. So 32% of the tidal volume was going to the ventral area. 53% was going to the mid-ventral. Only 5%, that's the area that was the most abnormal, was merely 5% with a dorsal distribution of 9%. The normal distribution for the ventral area is 8 to 15%, and the mid-ventral and mid-dorsal are usually 35 to 40, as well as 8 to 15% for the dorsal region. So we see the mid-dorsal region that is only 5% is pushing up the distribution of ventilation more to the ventral area and mid-ventral area. This usually happens when the gravity-dependent regions are collapsed and the more compliant region, which is usually the ventral and mid-ventral areas. So because we're unable to open up the mid-dorsal and dorsal, all that tidal volume goes to the more compliant area, and this can risk over distension. So I titrated the PEEP from 8 to 10, and then I further increased it to 12. I pressed the diagnostics on the Palmavista to do a PEEP trial or a PEEP trial analysis, and this is the results. So the minute we went from 8 to 10, we had a 10% loss of compliance in that shaded area. So you can look at the tidal image above and you can see that orange shading. That's telling us that there's a 10% loss in compliance in those specific regions of the lung. We increased it further to 12, and now we see again a increase in the loss of compliance in that shaded orange area, which is 21%. So the attempt from 10 to 12 to further open up the mid-dorsal and dorsal region is unsuccessful. Now I could have tried to go 14, 16, 18, and perhaps we would be able to pop that open and that would improve the compliance. So that definitely could have been an option, but I felt more comfortable just to try APRV, just to see, since the pressure isn't really opening up any of the lung compartments, perhaps pressure with a longer time would do the trick. And here's the results. So this is the distribution of ventilation on the APRV mode. You remember that a lot of the distribution of ventilation was kind of trapped in the ventral and mid-ventral areas because we were unable to open up the dorsal region. Recruitment is pressure over time, and in conventional modes we have access to pressure. We have the inspiratory pressure as well as expiratory pressure to help recruit the lung. But we're very limited in time, because often in inspiratory time, the patients don't really tolerate a 2-second inspiratory time on conventional modes. So we're often limited to 0.6, 1 second. But with APRV, since we have P high that can control the pressure, and we have the option of T high to extend well beyond 1 second, recruitment is pressure over time, and that's why often APRV is quite successful where unconventional modes are unable to open up areas. It's because APRV uses pressure over time. So we can also look at APRV as literally a mode that is a constant recruitment maneuver.